just going to run through a normal delivery, which once again, I think most of you have already been through this with Advance, but we're just going to go through it again just to make sure to refresh a little bit. The first thing you want to make sure is that you have your OB kit. And if you've never been in an OB kit or seen it, it will come in some kind of little package like this, right? And it'll have an assortment of things in here. You will want to make sure that you have goggles, some sort of goggles, eye protection, because I'm telling you, when they birth a baby, lots of stuff comes out of here. All right, lots of stuff that you don't want splashing in your eyes. Mucous membrane, you can have disease transmission through vaginal juices. So make sure, I don't know if juices is the right word, but we're going with it. All right, the things that come out can infect you with other things that you don't want. So make sure you wear your eye protection, okay? You will have some sort of little gown of sorts. You know, it seems woefully inadequate, but it's better than nothing. I've delivered 2 in the field. One of them I went back in scrubs from the hospital because I had so much stuff on me. It was gross. So don't do that. I suggest if you have long hair, pull it up, because if not, you lean down, you might dip your hair off in it. You don't want to do that. So make sure that you have all your stuff on. Other things, you will have some sort of absorbent dressing in there. All right, this is going to go down and it's going to go under her buttocks and hips and thighs, and this is going, okay, and this is going to help absorb some of these fluids that are going to come out. All right, we'll get to that in just a second. You will have some sort of sterile glove, maybe in a package like this, maybe in a package like this. Now, sterile glove application is a whole different skill to talk about a different day, but the gist of it, you want to make sure that you're not touching anything in here with other than what the non-sterile part is. And when you open it up and put your sterile gloves on, once those are sterile and they're on you, if you touch anything else, they're not sterile anymore. So this is going to be one of the last things that you're going to do. You will have your clips. I'm trying to get there. You will have your clips here. You'll have some kind of clip here. I recommend that you go ahead and kind of peel open the edge of this, so that way, because otherwise you get excited, you're like, oh, you open it up and then you spill them everywhere, and then you don't have your sterile clips anymore. All right, you will have 2 antiseptic wipes, one for each side of the vulva. You will have, if you got a Volvo down there, we got problems. You will have some sort of covering cloth. We'll show you what to do with that. You will have a bag of sorts. This is to put the placenta in if it delivers. Now, if it doesn't deliver, it may not, depending on how far away you are from the hospital. Some placenta may deliver, within a few minutes after the baby. Sometimes it may take up to 10, 15, or 20 minutes, so it's variable. You'll have some sort of like twisty tie, like a bread tie, to secure this up. If you don't have this, if you can't find it, toss it in a red bag. The placenta, not the baby. All right. You're going to have a maternity pad. This just looks like a giant maxi pad, basically, but without a sticky back. So this is going to tuck in. Now, when you tuck, we're going to tuck top to bottom, but we'll talk about that as well. You will have some sterile 4x4s or 2x2s or something. This is for any bleeding control that if they tear, because a big old thing is coming out of a somewhat smaller hole, so there's potential for tearing. This is going to help. We're going to put this there to stop that. You will have either a sterile scalpel, or you'll have some sort of scissor clamps, some kind of cutting mechanism to cut the cord once it comes out. Okay, you want to make sure that you have that in order to cut it. You don't want to just whip out your trauma shears and cut it off, because those are not clean. Okay, you'll have a bulb syringe. Depending on where it is, you may or may not have some sort of clamping mechanism. It's a good backup in case the OB kit clamps don't work. These are a pretty good thing to have handy anyways, but you have that, and I think that's everything that you have. I recommend that you have some towels. Have a stack of towels nearby. I'm telling you, I cannot overemphasize how much stuff comes out during delivery. So what we're going to do, we're going to come in, we're going to go, of course, our appropriate PPE. We've got our goggles, our gloves, everything on. All right, we're going to go ahead and we're going to run through. When are they due? When is the estimated date of confinement? What's their due date? How far along are we? And what I'm looking for here is, are we ready to deliver? If they're 9 months and 2 days, there's a decent chance you may be delivering this baby on the way to the hospital or even where you are. If we're at 6 months, I know that if we do deliver this baby, we have a much higher chance of problems, especially respiratory problems, because it's a fact it's not completely ready to go yet. So that's really what you're looking for there, to see what can we expect if we do go into labor. We want to find out the frequency and duration of the contractions. The more intense, the more frequent, the closer together they are, of course, the closer we are to actual delivery. So if we're 5, 6, 7 minutes apart, I'm probably going to try to go to the hospital and they don't feel the urge to push yet. But if we are, 2 minutes apart and they feel the urge to push, get ready. Somebody just asked to be admitted to the thing. I can't see who it is though. All right. Hi. So we are also going to find out, has the amniotic sac ruptured, okay? That big gush of fluid. If it has, what did it look like? Was it clear? Was it kind of yellowish tinge? Did it have meconium stain? If you said meconium stain, they're probably like, what? Did it have anything funky? Did it smell funky? Did it look funky? Or was it just kind of clear, almost more like a urine type output? All right, find out how long ago that happened as well. You can ask about the mucus plug if they've lost that or not. Some may realize it, some may not. It may just have gone and they never realized it. All right, you also want to find out about their GPA, not how they did in school, but their previous gravida, para, and any abortions that have occurred, right? So how many times have they been pregnant? How many times have they successfully delivered a live birth? And any that don't count for the live births, any abortions, miscarriages, stillborn, any of that counts towards the A. The more of those you have, the more higher chances of complications typically. So that's what we're looking. We're all looking to see how hard is this going to be for mom and subsequently us to help this delivery occur. Because we're helping. Don't make any sense. We are not doing this. Mom is doing this. We're helping. This process has been going on forever. So we're going to come in, we're going to find out any other medical histories, anything that they already have, diabetes, high blood pressure, cardiac issues, seizures. All of that has potential to be magnified during pregnancy and then subsequent childbirth. We're going to find out, have they had any prenatal care? Who's the doctor? What hospital are they using? Have they identified any potential problems during their prenatal visits? Are they taking their prenatal vitamins? If they don't take folic acid, then there's a greater chance of neural tube deformities or deficiencies when they're born. If they know that they've got a cleft palate, well, I'm a big fan of knowing what you're dealing with. So if you know they've got a cleft palate, we know automatically we may have a little bit more issue with airway. So we're kind of mentally prepared to deal with that a little bit better than if, surprise, you don't know what you've got. All right. Find out if they've had any vaginal bleeding, any abdominal pain, anything out of the ordinary. Of course, we're going to get our vital signs. You would probably want to consider an IV at some point, not necessarily right now, but just in general, in case something goes wrong later on. At this point, we've been here, we've been with her for a couple of minutes. Now we've got to figure out, are we going to see if we're about to deliver and we're going to set up all our stuff, or are we going to get in the hospital and hope in a prayer and try to make it to the hospital and deliver? If they're ready to deliver, you're not going to make it. So we're going to have to ask them, ma'am, do you feel the urge to push or like you need to have a bowel movement? All right, anything like that. The answer, we need to look and see. All right, so we're going to have them take their pants off, take their underwear off, and we're going to have to lift up. Obviously, you want to do this in a private area. If you're in the middle of the food court at the mall, not the best place to do this. Somebody else just clicked in to say it too. All right, so we're going to look. We're going to take a look. We're looking for any bulging in the vulva area. If it's kind of looks like it's poofing out a little bit, that means that there's something pushing down coming through the birth canal and it's kind of making it move outward a little bit, which means it's probably the baby coming down. All right, we are looking for obviously any baby parts hanging out, anything showing that says, hey, we're about to deliver this baby. All right, if you do, then you're going to prepare to deliver where you are. Now, depending on where you are in the residence or something, you want to make sure you have got room to work. You don't want to have it where there's a drop off and then, if something happens, you don't want that baby to fall from the edge of the bed to the floor or anything like that. You want to try to be at a good working height so you're not like this, leaning over, causing a bunch of pain or anything like that. So we are going to get all our stuff out. We're just going to assume that we've got time to do this. All right, we're going to have this, all right, we're going to put this up under your buttocks right there. Ideally, she'd lift up and kind of help a little bit. All right, once again, absorbent dressing. I like to roll a towel like this and tuck that right about there and make a dam to absorb some of the stuff that's going to come out.
So a dam absorber?
Yep, it's a dam absorber. All right, and then you put this underneath your sterile, and there we go. Now we've got a little kind of a area to keep some of the fluids from gushing all over you, because they will. All right, so now we're going to lay out our stuff. If you have time, you may take these little claws, and this is what these are designed for. They cover the legs. Like so. Like so. That's what we're doing. If you don't have time, that baby's halfway hanging out, you don't have time for that. Skip that part. Right? But do not skip this part. You take your antiseptic wipe, you wipe it open, you take one, you wipe down top to bottom, one side of the vulva, toss it, that one's done. Open up the other one, top to bottom, the other side of the vulva, toss that one. Not scrubbing, not back and forth, one side, one swipe, top to bottom, done. Now we have made this as clean as we possibly can for this baby about to come out. All right. When we are waiting for the baby to come out, we're going to encourage mom, hey, you're doing a good job, you know, help her with the pushing. Don't hold her hand, because that's going to tie up your hands. You need your hands. You want to sacrifice your partner, let them hold their hands, or if they have a support person, let them hold hands. But ideally, you're going to want to actually kind of have the legs flexed and up like this. And I'm going to see if they'll stay. I don't know if they will or not. Put that one down. All right, but you want them kind of flexed and up. It's going to help open up that birth canal, open up the pelvic ring just a little bit more, make it a little bit easier, hopefully, for that baby to come out. All right. You also want to, if possible, have her kind of elevated, so we've got a little bit of gravity helping us as well, but it's going to be a little easier to push, a little more productive push if you've got somebody kind of elevating her and she's kind of sitting up just slightly and not completely flat on her back. All right. So you get all your stuff out and about, you've got it here, you've got it all lined up nice and ready for you. The first one I did, I think I opened it and ripped it and the whole thing just flew everywhere, so I had to go to the second OB kit. So, you know, just take your time. You have that ready, mom's ready to push. And now we're gonna kind of wait and watch, and we're gonna be looking for this baby to start progressing down the birth canal. When we see it, okay, we're gonna wanna put our hand here, we're gonna kind of cover the entrance to the vulva and put your hand on that head when it comes out, so that way it doesn't just pop out with a explosive delivery and cause a lot more pain, because right here in the perineum you can cause the tearing, and they're graded, but we don't want to tear that if at all possible. All right, so we're watching, we're waiting, the head's starting to come out. You see it a little bit, it's starting to poke its way out. We're watching. All right, you're doing a good job, Mom. Push when you can. When you feel the need to push, go ahead and push. All right, now you can help kind of stretch the vulva just a little bit to help minimize the tearing. You're not putting your hands in there in any way or form, but you can help kind of stretch the vulva a little bit as that head starts to come out. All right, you've got your hand here to prevent this explosive delivery. All right, good job, Mom. A couple more pushes and that head will be out. You're doing good. Good job, Mom. Good job. A couple more pushes. We're almost there. All right. I can see the ears. I'm actually helping a little bit more than normal so her vulva doesn't fall out. She's had a couple of babies. All right. But when this head comes out, as soon as the head comes out, we're supporting the head, we're going to check around the neck, and we're looking for a nuchal cord, okay? If we have a nuchal cord there, most of the time it's typically going to be kind of loose, and you just loosely figure out which way it's wrapped, and you just slip it over the head. If you cannot slip it over the head at this point, we would tell Mama to pause, and we would have to clamp and cut that cord, okay? But for some reason we don't have one, so we're going to keep going. The baby is actually kind of rotating, and they should be in the shoulders on top of each other, one and then the other sideways, essentially coming out, so that way they pass through that birth canal. A couple more pushes, Mom. I can see the top of their chest. We're doing good. We want to still support the head because they've got floppy heads. They have no neck muscle control, so their airway is very easy to occlude like a little bendy straw. All right, one more good push, and then we got it. You don't want to push anymore. There we go. Good job. All right, so we're going to kind of come down, pull that bottom shoulder out, and then up to pull the bottom one. And then once the shoulder's clear, the rest of it just kind of slides on out typically. All right. Oh dear. There we go. Now, when we have this, you want to be very, very careful. Number one, support the head. Number two, make sure we're not pulling on this umbilical cord, okay? Because if it's a short cord for some reason, you can cause tearing and cause severe bleeding in the uterus, or you could pull on baby, cause severe hemorrhage with the baby. So we want to make sure that we're not pulling on this cord at all. All right, so we've got baby here. Now we are going to dry baby. We're going to take our blanket and we are going to dry and stimulate. Notice we're not cutting. There we go. That's a good cry. We want that good cry. All right. Now there's going to be, after the baby comes out, there's going to be a little waterfall of stuff that comes out. Up to 500 milliliters is totally normal and okay. And it looks like a lot. All right, but it should be like a gush, and then it should kind of trickle off. There shouldn't be much else coming out. If you still have a continual red blood coming out, they may have a cervical tear. We can't put pressure on that, so just be aware of that. All right, but we want to dry baby all the while supporting the baby. Once we've got baby stimulated, dried, then we are going to go ahead and cut and clip. May have to lower it down just a little bit. All right, so we're going to come out. I think the books say 5 to 10 centimeters. A hand is usually pretty good. All right, then we're going to come in and we're going to clamp. And then we're going to come out another to the second clamp.
Does somebody have a question? Oh, okay.
So now we've got our clamp here. Now we're about to cut, but before we cut, we really want to make sure, we want to feel and make sure that this in fact is not having a pulse, doesn't have a pulse in here, okay? It's not pulsating. If it does, and y'all don't know if you've ever felt an umbilical cord, but if you have, you know what I'm talking about. It feels to me like a really fibrous, almost like a garden hose type situation. It's very thick, a lot more fibrous and harder to compress than I actually thought it would be. But we checked, we do not have a pulse here. So now we take our scissors, we take our scalpel, and we cut. If you use the scalpel, I like to do the fold and cut away. Never cut towards, because if you slip, you cut baby, that's not a good day. All right, so fold it and just kind of cut up and away to cut through that. All right, but you always have to make sure you don't have that pulse there anymore. All right, once we have that done, now we're going to do one of two things, and it really just depends on the situation. We got to reassess mom, we got to reassess baby. So we're going to get our APGAR, okay, appearance. So what we're looking at is their overall appearance. So if their whole body is pink, they get 2. If their body is pink but their extremities are blue, then they get 1. If they're all blue, they get 0. All right, pulse, the next thing, if it's above 100, they get 2. If it's below 100, they get 1. And if it's not there, they get 0. Where do we check this? Remember, we check this in the brachial. Anybody under 1, we check in the brachial. All right. The next one, grimace. So this is kind of like the straightening of the legs, resistance. So their legs typically are going to be flexed up, kind of like a frog leg, and because they've been kind of curled up in there for, you know, a hot minute. So you want to try to straighten their legs a little bit, try to move their arms. They should kick and resist the efforts of you straightening their legs. If they have a strong resistance, then that is 2. If they've got a little bit of a resistance, but you can still move it around, that's a 1. And if they just are completely limp, then that's a 0. All right, or no resistance at all. The next one is going to be activity. So they should be moving around, kicking, flailing about. If they're strong, vigorous kicks, 2, weak, a little bit of movement, 1, none, 0. And then respirations. So it's not actual rate, it's the vigorousness of their cry. So strong, wah, wah, really strong cry, that's a 2. A weak or grunting or something like that, it's a 1. And then nothing at all, no respiratory effort, is a 0. So we get that APGAR. Now, if mama is good, we can let mama do skin to skin breastfeeding if she's planning on breastfeeding, okay? This is going to be good for baby. This is also going to be good for mama because it's going to release oxytocin, which is going to help with postpartum contractions of the uterus, which is going to help shrink everything up and stop the bleeding. Now, if we do this, we want to make sure that we take some dry blankets or towels and we cover baby up. We don't want baby to be exposed. They cannot regulate their temperature yet, all right? Now, if for whatever reason, if mama's not stable, if mom's not planning on breastfeeding, if mom does not want to do skin-to-skin contact for whatever reason, doesn't matter, not our place to judge, all right, then we would swaddle the baby. And so I'm gonna set the baby here for just a second. You would not set the baby down in the juices, but we're just gonna go because I've got limited space. All right. Yes, ma'am. No, I'm glad you asked because I meant to tell you about that and I forgot. So we do not routinely suction the airway anymore. All right, used to for years and years and years. As soon as that head popped out, you suctioned. You took your bulb syringe and you suctioned and you suctioned and you suctioned. Well, what AHA's current position is that doesn't really do a whole lot of good. The little bit of fluid that is in their mouth, they can handle adequately. And we actually cause more harm than good by sucking out the oxygen along with any fluid, meconium or amniotic fluid that may be actually in there. So what their current recommendation is do not routinely suction. If they have respiratory distress, so if they've got a poor APGAR score, if they've got poor respiratory effort, if they show signs of respiratory distress, then you suction. Okay. If they don't, let them roll. All right, and so, all right, we got swaddlers. Mom can't do this for whatever reason, no skin to skin. All right, we will actually, and I'm not a great swaddler, but we will kind of swaddle the baby to keep them nice and dry. If you have a hat, you would put the little newborn beanie on, and then we are going to swaddle the child, okay? Now, this puts you in kind of a dilemma because when we transport a baby, they are supposed to be in a car seat, right? So this is all stuff that is in theory and on scene. When you go to actually transport, you should have a newborn car seat to put this baby in and then cover it up and keep it warm in there. All right, because if mama's holding it and you get in a wreck on the way to the hospital, she's not gonna be able to maintain holding this. Baby's gonna go flying like a football. All right, so this is more of a on scene type thing. Go ahead and get that going. But that's how you do this, and now you got your little swaddle baby, like a little baby burrito. Now, from this point, all right, we're going to do a couple of things here, a little bit of aftercare. Again, we've assessed our newborns. Now, as far as the assessment of the newborns, all right, we're looking at the respirations and the pulse of the two big ones. We're going to do APGAR right after birth, so like 1 minute and at 5 minutes, okay? If their respirations are if their pulse rate is 100 or less, we are going to assist them with ventilations. We're going to BVM them, all right? If their pulse rate is below 60, we're going to start compressions as well as manual ventilations. All right, that's really important that you remember that part of it there. Now, as far as the assessment of the mom after birth. Now, have you noticed that this is a whole lot for one person to do? Go ahead and call for another unit. You got your partner there, but at some point your partner's got to go drive. So go ahead and call for another unit, because if anything goes wrong with either of these, you're going to need another medic to take one of the patients. You cannot adequately take care of both patients if one of them or both of them are critical. So make sure you get another unit come in as well. All right, but so what we're going to do is we're going to, somebody say something? Okay, we're going to palpate. Now, pre-delivery, the fundus, that part that you feel up here, should be up here, somewhere between the belly button and the bottom of the ribs, okay? You should be able to palpate. It should feel like like a muscle in there. Right after delivery, it should be down around the umbilical area, and it should feel like it should start to harden up and tighten up, and it should feel like a softball in there. All right, it should feel like a softball. You should be able to feel it. If you cannot, or if it's, they call it boggy, if it's a boggy uterus, if it's squishy feeling, pokey, that's not good. That means the muscles are not clamping down and secure or slowing that bleeding, okay? So you have to do a fundal massage. Now, you don't do the fundal massage until after the umbilical cord has delivered. We don't pull this, because if we pull this, you rip it away from the interior lining of the uterus, and you can cause severe hemorrhage and even uterine rupture, which could be life-threatening. All right, you can also cause a uterine prolapse, where the whole thing will turn inside out and drop down through the birth canal. Also not good. All right, so the way the placenta is going to deliver, they're going to feel like they're having contractions again. All right, they'll have a couple of contractions, and then they will expel the placenta. You want to take a look at it and see, does it look intact? It'll have a really thin membrane on it. You want to make sure that there's nothing missing, nothing has gone anywhere from it, because if it is still in here, they're not going to stop bleeding like they should. But you look at it, everything looks good. We're gonna drop it in the sack and take it with us to the hospital. All right, at this point, we're gonna reassess. Is that uterus firm? Feeling firm? If it's not, then you're gonna put your hand here on the pelvis. You wanna support the lower end of that uterus so we don't push it out and invert it on accident. You're gonna take your fist, okay? It's not like a general little massage, it's like fist. And you're gonna take it and you're going to kind of massage like so, and almost like you're digging in to try to make that uterus kind of almost manually constrict and contract and tighten up, which will slow that bleeding. All right, so we've got this done, we got the placenta done, your medic partner's taking care of the baby. The last couple things we're looking at here. All right, if they have any tearing right here in the perineum, then we're going to take our little sterile 4x4s and we're going to just put them up against it like so. Then we're going to take our OB pad and we're going to take it, the top end, and just kind of tuck it up underneath there and have them close their legs. All right, and now we're going to transport to the hospital. That's about it. All right. Now, if you get on scene and they're not about to push, it doesn't look like they're about to actually have a delivery, don't have them put their underwear back on. Leave their pants off, leave their underwear off, because there's a good chance you may have to stop on the way to the hospital and deliver it. All right, that was my first one. I was like, yes, another one's gonna make it to the hospital. And we made it like 6 miles down the interstate, and then the water burst and went whoosh, and that was all she wrote. And so then we delivered on the side of the interstate. So, you know, don't assume just because it's not happening right now that it won't happen. So leave those off, just cover them up, put a sheet over them to provide for modesty as needed. All right, what do y'all have for me? Any questions? Yes. I missed part of that question. I think you were asking about like order of births if you have multiple births. Oh yeah, label your babies. And as far as a delivery of the placenta with the baby, it depends on whether they're fraternal or identical. You may have baby placenta, you may have baby placenta. So there's a couple of different ways it could actually go, just depending on whether they share a placenta or whether there's multiple placentas in there. Yeah, but yeah, definitely label your baby so they're not mistaken identity their whole lives. As I say, and what I would do would be to take, because you know I love my silk tape. I would take a piece of silk tape and stick it on their swaddle, whatever I've got them wrapped up in, not on the baby, of course, but like on their swaddling stuff, and write baby 1 or baby 2, or if you have their names, then that, but you know, baby 1, baby 2, whatever, that way you can keep up with them. You could consider, I mean, it's a little outside of the box, but you've got those bands for the IO stuff that, you know, if you ever don't use it for some reason, you could keep those handy, and you could write it on there and just attach that to their leg or their arm or something. But that would be my first thought, would be that I would just put a piece of tape on their swaddling stuff to keep up with them. No, we're not sharp. We Sharpie adults. We don't Sharpie babies. Nick just walked in and went, what?
Yeah, you draw him a little cute little Sharpie mustache. Why would you Sharpie a baby? What
We're talking about multiple births, keeping up with the different ones.
Oh.
All that can go on the tape on the swaddling stuff. Leanne, do you have questions? Wouldn't be a bad idea. Because one baby you can write it down on your piece of tape on your leg, no big deal. But yeah, if you have multiples, that's probably a good idea to put on there as well, so you can keep up with the different times. And as far as the tape, I already said, Travis, you don't put the tape on them, you put it on their swaddling stuff. And you know, backing up a little bit, when you're getting ready to transport, with the whole transport guidelines, might not be a bad idea to actually grab the car seats too if they already have a newborn car seat. might not be a bad idea to have that handy just in case. What else? You'll do 2 times at least. You'll do the number 1 at 1 minute, and the number 2 you'll do at 5 minutes.